Hello there friends, this is Dr. Vipin. I am going to present a case scenario for you to interpret the possible diagnosis. Well, what are you waiting for? Let's dive in. A 30-year-old male NRI patient visited your dental clinic yesterday. As he was leaving to Muscat after a few weeks, he wanted to get scaling done and his problematic tooth fixed. His chief complaint was discoloration of upper front tooth for the past 4 years. The patient recalled a history of trauma in the offending tooth 4 years back, which happened when he was playing football with his local friends in Muscat. Although the tooth was asymptomatic, it started to develop blackish discoloration. Endodontic treatment was done 3 months back. However, he failed to rehabilitate the tooth with a prosthetic crown. He is a known allergic to pollen and has history of asthma and is taking medication for it. He is also taking medication for hypothyroidism and is under control. The intraoral examination revealed discoloration in relation to tooth number 11 with clinically healthy appearing periodontium. The tooth 11 showed no signs of mobility and was non-tender to pressure and percussion. The patient was advised for intraoral periapical radiograph, anterior occlusal and panoramic radiograph for radiological evaluation. His OPG revealed a well-defined horizontal radiolucency of the incisal third of the crown, with reduced overall height of the crown suggestive of attrition. There was a homogeneous radiopacity involving the entire pulp chamber and the canal, suggestive of a prior endodontic treatment. The radicular and the periodontal ligament portion appeared radiographically normal. The lamina dura was obliterated at the apical third of the root. There was a well-defined radiolucency of the periapical region with respect to 11 of size approximately 1.25 cm into 1 cm with cortical margin, its epicenter lying 5 mm apical to the root apex. There was no evidence of root resorption or displacement of the adjacent teeth. The radiographic findings are suggestive of what type of cyst. Surgical enucleation was done under local anesthesia after obtaining an informed consent from the patient. The operating site was anesthetized with 2% lignocaine containing 1:100,000 adrenaline. Sulcular incision from the region of 1321 was given. Then a vertical incision nasal to 13 and distal to 21 was given, and a trapezoidal mucoperiosteal flap was raised. The overlying thin bone was removed with burr under copious irrigation to expose the cystic mass. During the procedure, the cyst was found to be infected with evidence of pus discharge from the cyst. The cyst was enucleated and thorough curettage was done. Flap closure was done with 3/0 silk suture and the specimen was sent for histopathological examination. The histopathological examination revealed a cystic cavity lined by non-keratinized stratified squamous epithelium arranged in an arcading pattern interspersed with intense inflammatory cell infiltration consisting chiefly of lymphocytes and plasma cells. Russell's bodies were also noted at places. What is the possible differential diagnosis? 1. Is it odontogenic keratocyst or OKC? 2. Is it a traumatic bone cyst? 3. Surgical ciliated cyst. 4. Radicular cyst. 5. Periapical granuloma. 6. Giant cell lesions. Hope you all like this new concept of making videos. Please subscribe to my channel and hit the like button for more thrilling videos like this. Thank you all.